Okay, I think we are recording. So I think we are quite a lot of people connected now. So I will just do a brief introduction. So good afternoon, everyone, and welcome again to this month's Sustainable Kidney Care Network meeting. It's again fantastic to see so many dedicated professionals joining us once again to share insights, innovations, and strategies that drive more sustainable kidney care. So today we are honored to welcome Dr. Stewart Lambie, consultant nephrologist at NHS Highland, who will be speaking on the implementation and environmental impact of incremental hemodialysis. Dr. Lambie brings over 20 years of experience in nephrology and a strong background in quality improvement. He served as a clinical director for medicine for 5 years, using QI methodologies to drive meaningful improvements in renal services. Since 2020, he has led the introduction of incremental twice-weekly hemodialysis in NHS Highland, demonstrating significant patient benefits, cost savings, and environmental advantages. His advocacy for this approach has extended beyond Scotland, influencing practice in New Zealand during his sabbatical year. So in this session, Dr. Lambie will walk us through the implementation process of incremental hemodialysis, the initial obstacles, setup challenges, and ongoing complexities. He will also discuss the patient financial and environmental benefits of having around 30–40% of this dialysis population, of the dialysis population on this regime. Following the presentation, we will open the floor for a discussion where we encourage you all to share your perspectives, raise questions, and explore how similar strategies might be implemented in your own setting. As always, your participation is key to driving change, and we look forward to a productive discussion. With that, let's get it started. And Dr. Lambie, thank you very much for being here today, and the floor is yours.
Thank you very much for that very kind introduction, and bear with me while I get this onto Teams, which it promised me I was going to be able to do. Is that coming up a slideshow now?
Yes.
Yep.
Excellent.
Yeah.
Okay. Grand. Right. Thank you very much for the introduction. I'm going to talk to you about incremental hemodialysis in Highland. I should start off by giving credit to two people or two places before I forget and miss them out. One is I usually present this along with Stewart Ross, who is one of our clinical nurse specialists who was key to implementation of this and still is a vital part of running it. And the other one is the Lister Hospital in Stevenage, who were been doing this for a long time, and we pinched ideas and some of their Excel spreadsheets and the way they did things a bit. So that's the credit given. I'm going to talk to you about NHS Highland and about incremental hemodialysis, and this is just an introduction to where we're talking about. I'm based in Inverness, in the middle there, but some of the benefits of this and some of the impact that we've had on travel times and costs of transport relate to the fact that this is a large area that we're covering. So relatively small population. Our overall population when it comes to dialysis is probably around 300,000 people. We've got about 100 patients overall on hemodialysis. So when I'm talking about some of the facts and figures later on, you can scale that probably up, because most of you will be working in slightly bigger centres than that. We cover Inverness down here. If you can see the cursor, we've got satellite units up in Caithness in the top right, in Skye, sticking out there on the left in yellow. We've got one in Stornoway out on the Isle of Lewis, and yesterday I was down in Fort William in the middle of Loch Aber. So that's the setting for this, and then most of you, I would presume, would have an idea of what incremental hemodialysis is. This is the schematic picture representing it, but it boils down to, at the start of hemodialysis, you need less hemodialysis because you've still got relatively preserved residual kidney function. And what I'm really going to talk about is the first slightly variable period in which you can dialyse patients twice weekly rather than 3 times weekly until their residual kidney function drops off enough that you need to convert them back to or up to 3 times per week. So we looked at this back in 2020, at which point these guidelines were still in place. We reviewed the evidence, which was patchy. There are small case series, small trials suggesting that it's feasible, and slightly variable results, some of them suggesting preservation of residual kidney function, some of them suggesting there might be a mortality improvement, but not enough to really definitively prove either of those things. Kay Doki said dose of dialysis may be reduced if you have preserved residual kidney function. The UK Kidney Association at that time said lower dose targets, and if you're going to do that, you need to quantify residual kidney function intermittently on incremental schedules. So they're not saying do that, or they weren't then saying do this, but they were essentially giving a nod and a wink to say that this is possible to do. So our question boiled down to this: can we use incremental hemodialysis for all of our incidental hemodialysis patients? And that's a slightly simplified version, because even at the start we recognised that there were going to be some patients who were not going to be suitable. So the prime example is if you remove a second kidney, somebody immediately has 0 residual kidney function and is not going to be suitable. But we essentially started out from, can we use incremental hemodialysis for everybody unless there's a very good reason why we shouldn't be doing it, is the slightly longer, clunkier version of what we set out to find out. So what did we think we were going to achieve? And it's interesting preparing for this talk to look back and see what our thoughts were at the time, and did we achieve what we set out to. And at the start, these were our prime motivators behind what we were trying to do, and of, I suppose, a variable weighting. So we were trying to improve the patient experience. It seems self-evident that coming to hospital twice a week rather than 3 times a week will be better. We were trying explicitly to save money, and it was always going to be cheaper if it's successful. We should be able to make it a cheaper way of delivering dialysis. Avoid inequality or inequity in there, and I suppose we weren't necessarily trying to improve that, but trying to avoid introducing inequity, because I was worried that if we introduced incremental dialysis in a piecemeal fashion, we'd be tempted to use it and get the benefits for our favourite patients, the patients who are easier to do it with, the patients who we like, and that would probably widen the inequity that we already have in hemodialysis. So I was keen to make sure that if we were going to bring it in, we tried to bring it in for everybody, unless there was a good clinical reason. Why not? We thought we might preserve residual kidney function. And along with the cost saving, we knew that if it was successful, then we would inevitably reduce waste. So that's what we were setting out to do. What were we worried about at the start of the project? And we'll come back to both of these to see did we achieve what we set out to, and were we right to worry. So we worried about would the patients agree to increase to 3 times a week dialysis? We wondered how reliable they would be about doing their 24-hour urine collections to check that they were getting enough dialysis. I could have put mortality in either of these 2 slides. We thought we might improve mortality. We worried that we might have a negative impact on mortality. We wondered about the electrolyte flux over the long gap. So there's an increased risk of death after the long gap between dialysis sessions on a 3 times weekly schedule. So were we going to make that worse? And we wondered if we were going to have an increased hemodynamic stress on the patient because of fluid shift. Are we going to be removing the same amount of fluid but in only 2 sessions per week rather than 3, and therefore have to remove fluid at a faster rate and put that hemodynamic stress on them? So those were the main concerns that we identified, and this is what we set out to do. So we said that we were going to start everybody starting hemodialysis on a twice weekly schedule, provided they had residual kidney function with a urea clearance of more than 3 mils per minute, provided they were still passing more than 0.6 litres of urine per day. We said at the start, infrequent history of hyperkalemia and potassium generally less than 6. That's got a star against it because we pretty soon realised that that didn't really make sense for a starting point for incremental dialysis, and removed that as a question about whether we would start somebody on an incremental schedule. And similarly, the fluid status, we said they needed to be fluid status stable, with fluid overload not being the primary reason for starting hemodialysis, but that ended up not being so much of an issue. And we said, and still do a bit, patients with good understanding who will accept increasing their dialysis time frequency in the future, and I'll come back to that later on. So we've simplified our admission criteria now, and this is what we say now and have done for the last couple of years. You need to have a urea clearance and a 24-hour urine volume as there, and we've still got that line in. I think we pay less attention to that because our experience is that that the patients have had good understanding and that they do accept increasing their dialysis time. The frequency is really the main thing. In the first phase of this project, we had a couple of patients who we invoked the 3rd clause there and said we didn't think that they were going to have sufficient understanding. And in hindsight and with more experience, I think we were overly paternalistic. And in fact, both of those patients should have started on incremental hemodialysis. And I'm not aware that we've used that line to say that somebody shouldn't have twice weekly dialysis since that early first couple of years those first 2 patients were. So that's who we said we were going to start, and these are our reasons for increasing to 3 times a week hemodialysis. And these first 4 are on there. The second slide gives you the ones that we actually use now. So these are still in our list of these would be reasons, but we have rarely, if ever, invoked these as reasons for increasing to 3 times a week. So if you have problems with high potassium levels, you'd want to increase to 3 times a week. If you've got problems with fluid, then increase, and failure to thrive. So we've got general get out clauses. If people are not doing well, then increase them to 3 times a week. But these are the ones that are mostly the reasons for escalating. So residual kidney function dropping below 3 mils per minute. And we were pretty twitchy in the first phase. And as soon as you had a single measurement that was below 3, we switched you. We're now a bit more relaxed and say, well, you might have one reading, one measurement, that one 24-hour urine collection that gives you a urea clearance of 2.85. Let's wait to see if that's repeated rather than changing you over straight away. And similarly with the 24-hour urine volumes. And we've got a measurement in there of your total weekly dialysis clearance. So those are the sort of guideline things. That's how we set things out. And then we had what's really a quality improvement implementation. How do you manage change issue? And I'm going to talk through these three. I grouped them sort of into three clusters. So there were issues about the culture within the department, quite a few issues and challenges around the logistics, and patient behaviour, which sounds a little pejorative, but it's not really. And I've clustered some things in there that are kind of patient behaviour related. So the culture, we started with the consultant staff, and when I mentioned Stewart Ross, when he does this presentation, he has in his presentation at least 3 times used the multidisciplinary team meeting. And that's because when I started this, I just wanted to find out if incremental hemodialysis was something that we could do. So I started a couple of patients on twice weekly schedules, and then at that stage we were rotating round as consultants. So I started them on a twice weekly schedule, and a couple of months later they would get seen by one of my colleagues who would look at them and go, what on earth are they doing on twice a week schedule? We don't know anything about this. We'll put them onto a 3 times a week schedule. So Stewart in his presentation says multidisciplinary team meeting because it's a vital part of doing this, and he's kind of right. So having had 2 patients and a couple of experiences, I then presented to and persuaded my consultant colleagues that this was something that we would try, and we would collect the data and see if it worked. So having got agreement from them, we then presented to the wider MDT and set off to try and do it. But the other staff were interesting because the feedback later on, I hadn't anticipated this, although maybe probably should have done, but we have experienced nurses who have seen a lot of hemodialysis, and like me, I guess I've worked in a centre where there had been patients on twice weekly hemodialysis and had seen them doing really badly. And so when we said we were going to dialyse some of our patients twice a week, there was some I'd say resistance, but I'm not sure it was quite resistance. Skepticism is probably a better word. They were not sure that this was going to work, and probably some reluctance maybe to implement it. But they went along with it. But it was maybe something that we didn't identify as an issue that we needed to address, and therefore didn't. So we managed to implement this despite that, but it might be something that we would have been better if we had addressed it at the start of the project. Logistics, we knew were going to be difficult, and they were. So the 24-hour urine collections now work reliably and well. It took a while to get there. It took the nursing staff learning what they were asking for. It took the lab staff a bit of adjustment. We kept on getting things back with creatinine clearances or 24-hour urine sodiums or proteins or whatever, just getting it wrong. Now it's in a routine, and one of the things that we learned was that you get a lot of the benefits when you reach a critical mass, and we had more difficulty and less benefit when we had a patient here and a patient there, but a lot of the logistics became better when incremental hemodialysis just became normal and standard, and we had enough patients that we were seeing the benefits of it as well. So 24-hour urine collections being a good example of that. Results handling was another issue. So we're monitoring our patients in line with our regular dialysis quality blood testing schedule, which is 6 weekly. So we're doing 6 weekly, 24-hour urine collections, and then those results get put into an Excel spreadsheet, which spits out the things that we want to know: the 24-hour urine volume, the residual urea clearance, and the total weekly KT over V. And then we put those results in front of the consultant reviewing the patients, and it became apparent that we needed to do a little bit more than that, because it's just another result to a consultant who's not an enthusiast like I am. You have to try and remember what's the threshold for urea clearance and what's the threshold for the urine volume. So now what happens is Stewart Ross, my nurse colleague, provides a little bit of commentary with it. So these were the results, and you may wish to, so no changes needed if they're all above threshold, or you may wish to talk to them about changing to 3 times a week dialysis maybe next time, or you might wish to lengthen their dialysis time per session to get the total KT over V up, or this looks as if you need to change to 3 times a week now. So there's a bit of commentary that goes with it to enable consultants who are not enthusiasts to have a better idea of what the results mean. Scheduling is something that we get asked about a lot. I don't have an answer for it. It's a difficult problem. You get benefits. So the issue here is that you're trying to work out scheduling for some patients on 3 times a week dialysis and some patients on twice weekly dialysis, and trying to match them up. So you might be trying to arrange transport for 2 patients who come from Nairn 15 miles away. You're trying to get them both in the same taxi, but they both come on Monday, and then one of them comes on Monday, Wednesday, Friday. The other one comes on Monday and Thursday. So you've got to try and match them up, and it doesn't work. So the scheduling is one of the few downsides, but it is more complicated. We don't have a computer program to help to make it easier. It is a more complex thing. You start to get benefits from it, which we'll come back to later on when I get to the benefits, but you save dialysis slots, because instead of having 2 patients taking up a Monday, Wednesday, Friday, and a Tuesday, Thursday, Saturday, you have your 3 incremental patients taking up those same 2 standard slots. So you'll have a patient dialyzing on Monday and Thursday, one on Tuesday and Friday, and another one on Wednesday and Saturday. But so scheduling is difficult, and the transport difficulties are similar. Like I said, you might previously you could have all your patients from one area getting the same transport on the same day, and you just put them all on the same shift. It just works. And now transport is more complex than that. So patients, what about them? So I said that we were concerned, would they be willing to go up to 3 times per week? We know that patients can be a bit resistant to increasing the length of time that they're attached to the dialysis machine for. In our experience, they're readier to increase to 3 times a week than they are to go up by more hours, to increase the length of time per session. And I think that's partly because we prepare them. So most of them are coming through our advanced kidney care clinic, and most of them are being told from the start that when you do hemodialysis, you will start twice per week. You will monitor your urine output, and at some point you will increase to 3 times weekly. So they're prepared ahead of time. And the other thing is that they can often see themselves when they're getting closer. They will hand their urine collection in and say, it's getting less, isn't it? That's going down. I'm going to need to go up to 3 times a week. So they feel some agency, I think, because they're doing the urine collection themselves. It makes them feel a bit more involved, and it just seems more acceptable. We've had 1 or 2 patients who've actually chosen to do their incremental hemodialysis with shorter hours 3 times a week rather than longer hours, because the length of time on the machine is so unpleasant. But increasing to 3 times a week, we have yet to have somebody who has refused to go up to 3 times a week when we have recommended it. Urine collection. So I've said that that isn't an issue. There's an issue occasionally. Generally, they're engaged with it. They know why it's being done, and they know that without the urine collection, we would need to change them to 3 times a week. There are occasions when it gets forgotten, and that's either us forgetting to give them the form or the bottle, or they forget to fill the bottle. So it can be late, it can be delayed, it can lead to a bit of chasing up, but it's again, I'm not aware that we've had anybody who simply refused to do the urine collection. If they did, we would be having a conversation about needing to go to 3 times a week if we don't have monitoring in place. Prevalent peeing patients, peer pressure, I put in obviously because I just couldn't resist the alliteration. That's because we started with our incident patients. We had a couple of patients, not many, but we had some patients looking around saying, why is he on twice a week when I'm doing 3 times a week? And there were a few patients who we converted having started 3 times a week, and in the first couple of years when we were just implementing this, we had people who'd been on for less than a year, but up to, there was one guy who'd been on for 3 years, and he said, why can't I be on twice weekly? And I said, because you've been on for 3 years, you'll have lost your residual kidney function. He said, no, I still pee absolutely loads. Well, I'll measure and see, and he was right. So he had an extra 9 months of when he went back to twice weekly hemodialysis before he had to increase again. But yeah, a bit of peer pressure when people saw what we were doing. Patients saw what was happening in the unit. And review opportunities, that's gone down as patients, but it's more a reflection of our schedules. So this is about the fact that you don't see the patients as much, so they're just not there, and it's especially the ones who are dialysing. You might dialyse on a Wednesday and a Saturday, and that just gives you one opportunity to review that patient per week. And if that Wednesday, if they're your patient and they're dialysing on a Wednesday morning and you have a clinic on Wednesday morning, you can't actually review them. So it's a little bit more difficult to review them. Having said that, they're usually the better, weller patients, and they don't need as much review, but it's noticeable that you need to put a little bit more effort into catching the patients if you do need to see them to sort out medical issues. So these are our results. When we last counted them up, we'd started 120 patients on hemodialysis, and 115 of them had started incrementally. The 5 included an anti-GBM who just didn't have any residual kidney function left, or not enough to start incrementally. And there were others who would go into the crash lander phase who were late presenters. Having said that, we've had more late presenters than 5, and what we do now for people who present either very fluid overloaded or with very severely deranged biochemistry is we start them on 3 times a week and get things under control, and then review where they've got to. And if you've removed 15 litres of fluid over the first 3 weeks, 4 weeks, and you've got them euvolemic, you've started them on frusemide and they're peeing and they're a bit better, then you might consider changing them to twice weekly. So we're now, the 115 out of 120 tells you that we start pretty much everybody on incremental hemodialysis unless they've got a good reason why not. And that means we're probably in steady state, and it's probably closer to 40%, but we're relatively small numbers, so we do fluctuate a bit. But 30 to 40% at any one time of our dialysis patients are dialysing twice weekly. And I talked about us being a small unit, probably in a bigger unit, but if you apply the percentages, then you can work out the equivalent benefits that would accrue to your patients if you were going to start using incremental hemodialysis. So 30 to 40% of your patients dialysing twice a week instead of 3 times a week means that you are saving 10 to 13% of all of your consumables. Median days on twice weekly, 518. I'm not sure how scientifically accurate that figure is, but it shows you that most of the patients will stay on for more than a year. Some extend, and I'm not sure where the phrase decremental dialysis comes from, but we've had a few patients who have either, so we had a few that went up to 3 times a week and said, I don't like this, this is not for me, I'm going to go back down, and with our blessing, converted back to twice weekly. One of them was on Mull, and so he had a drive, a ferry, and a drive to get to the dialysis unit in Fort William, and he was older and less well, and actually it seemed entirely reasonable for him to say, well, I've tried 3 times a week, I felt worse doing that journey and getting more dialysis, I'm going to go back to twice weekly. And if you feel better doing the less frequent dialysis, then carry on. And we had a few who we decided that just converting to 3 times a week purely because their urea clearance was 2.3 didn't make sense, and some of them have gone on for significantly longer and died of other things while still having incremental hemodialysis, while still dialysing twice weekly. And I've talked about the no refusals to convert and the reminders for 24-hour urine collections. Our patients have thrived. That's probably the biggest thing, is we have seen them do well. We haven't looked at them and thought any of these people are sick and ill and need to go to 3 times a week dialysis. They look well, they feel well. 24-hour urine and the total volume can be an issue. We're using more higher dose diuretics, and we probably need to study that a little bit more. I was interested to see in my time in New Zealand that they were using much bigger doses of furosemide in more of their patients. We've started to use more because we're focused more on the fluid balance side of things. And we find that 24-hour urine is actually quite useful. It helps with the next line I've got there with the neutral balance for target weight. If you know that your patient is passing 1.5 litres of urine per day, which is quite common, then logically there is no way that they should be retaining enough fluid for them to need to have fluid taken off on dialysis. So we're far more likely to prescribe them a neutral balance for target weight, and to be a bit more confident in that, knowing how much urine they are passing per day. And the dietitians find it useful, and it lets them be more relaxed with their fluid restrictions, which feeds back into better patient acceptability. Again, there's no point in telling them to restrict their fluids if you know they're peeing 1.5 litres. The electrolyte issues have not materialised. We haven't, as far as I am aware, we haven't had to convert anybody because of electrolyte issues. We don't run into hyperkalemia as an issue. Fewer admissions, probably. That's based on quite small patient numbers, because that was an analysis of very small numbers and early phase. But when we looked at the first cohort of patients going through this, they did have fewer admissions than a matched cohort who had started 3 times a week. Looked as if that same cohort had similar access issues. We use buttonhole needling in most of our fistula patients, and they're more difficult to establish when you're only dialysing them twice a week. It's a small price to pay. So that's what we achieved. Those are some of the numbers, and there's more numbers to come, but these are we got some patient feedback, and these are just some of the quotes. They were uniformly positive about astonishingly uniformly positive about the idea of dialysing twice a week rather than 3 times a week. And these are some of the things that they said they enjoyed and appreciated about having that extra day back to themselves. and the costs. So we've so far saved £250,000. I've got that as your 10 to 13% because your numbers will be bigger, your budgets will be bigger. But however big or small your budget, being able to say that you can save 10 to 13% of your budget is colossal. And it's a relatively crude analysis, that. So we've looked at saved taxi costs, saved consumables, saved waste disposal, and saved drugs. We haven't found an easy way of measuring the energy costs, but we're using less energy to dialyse our patients. And we haven't factored in the saved nursing staff, nursing time, but we know that we've closed one dialysis shift. We were doing 2 shifts per day and 1 evening shift, and now we're doing 2 shifts per day and an evening shift, but only 3 times a week rather than every day. So we're fewer dialysis shifts. And eco-friendly savings. So far 5,000 haemodialysis sessions avoided, and that's led to 10,000 kilos of non-recyclable waste, 225,000 kilograms CO2 reduction, a couple of million litres of water that we haven't used, and the travelling distance for our patients, so 164,000 miles, which contributes to those taxi costs. But not all of our patients come in by taxi, so there's savings from, there are green savings from those miles not being travelled, whether that's by ambulance, private car, or by taxi. So back to where we started, did we improve what we set out to? Well, yes, we improved patient experience. We definitely reduced cost. I'm confident that we've avoided introducing inequity. I have a question mark. We can't measure it because we didn't measure residual kidney function previously. I think that we probably do preserve residual kidney function better now because we're not producing that hemodynamic disturbance 3 times a week. It's only twice a week, and we are paying more attention to not removing so much fluid where we know that the patient's still got significant urine output, and that probably helps with that, but I can't prove it. Reducing waste, we've definitely reduced waste. Did we need to worry? Patient agreement 3 times a week? No. Urine collections, maybe, in that we thought it might be an issue, so we concentrated on it, and it proved not to be a significant problem. Mortality, I can't tell you that mortality is better with incremental hemodialysis. I can't tell you that it's worse. I would argue that even if mortality was a small percentage higher, I think it would be outweighed by the fact that we're keeping people out of hospital for an extra day every week, and there's no point in living for a few more days if you're going to spend a lot more days in hospital. Our experience is not that mortality is higher. Our patients look as if they remain well. We haven't detected any difference. Electrolyte change, long gap. Again, we haven't seen people with problems. We haven't seen unexpected deaths. We don't see high potassiums in our twice weekly cohort. And the fluid shifts, again, because we've defined that they need to have 600 mils of urine output per day, the cohort that we have on twice weekly hemodialysis are not having problems with fluid shifts. They do get down to the stage where if your urine output is less than a litre, then we can have to start removing some fluid on hemodialysis. We're not keeping them all in neutral balance, but it's a small amount of fluid, and it's rare that we need to change them to 3 times a week purely because of fluid. So, in conclusion, incremental hemodialysis for nearly everyone. It's patient-friendly, it's eco-friendly, and it's cost-saving, and it's been very successful in our area. Thank you very much, and I will stop sharing, and we can have questions and discussion.
Thank you very, very much, Stewart. It's excellent presentation, excellent, and I think it has answered almost all the questions I wanted to ask you. So
Okay.
let's see if there is someone in the audience, or someone that's been listening who want to ask something. I can't see them all, but just to begin. Oh, Elena, thank you.
Hi,
Hi,
Stewart.
Anna.
I guess less of a question and more of a comment, because most of my patients now start incremental as well, or decremental for the frail elderly. And actually, I find having an incremental protocol has definitely made me think about dialysis in a much less paternalistic way, as you say, and consider decremental as well for patient quality of life. But just a couple of reflections, and I wonder if this is your experience. You mentioned like diuretics, and I certainly find that optimizing the urine output so helpful. And the historic thing of, well, now they're on dialysis, just stop the diuretics, they don't need them anymore. Can't really believe we ever took that approach, because if you can really maintain the urine output, and sometimes I often use combination high dose furosemide with bendroflumethiazide, it also helps control the potassium.
Yeah,
Oh.
She's frozen.
She's frozen, yeah.
Yeah. Oh, you're back.
Sorry.
Yeah.
But along with that, I find, because we prescribe alpha calcidiol only 3 times a week post dialysis, we lose some of their phosphate calcium control if I'm not adding in a midweek dose for them. Is that something you've noticed?
No, because we don't usually give our alpha calcidiol post dialysis. We do if we think they're non-compliant, but that would be the only reason we usually is just using it daily. But I'll pick you up on the diuretic point, because New Zealand concentrated my mind. They had a third of their patients on 250 milligrams of furosemide or thereabouts. They had another third on 500 milligrams or more. And the biggest dose I saw was 1 gram twice a day, which was quite eye-watering. But only one patient, so we can exclude that. But quite a lot of them on 250 or 500 milligrams of oral furosemide, and they're now doing incremental hemodialysis because I introduced it, but they were doing their diuretic thing beforehand. And the issues I'd heard here, whenever I said diuretics and high dose, people say, what about the side effects and hearing loss? And the guys in New Zealand just looked at me as if I had 2 heads when I said that. No, we don't get that. They weren't looking for it, to be fair, but they didn't have any qualms about prescribing a hemodialysis patient 250 or usually 500 milligrams of furosemide. So yes, we're going to. It's one of my plans is to do a bit more of a study to see can we show what benefit you get from it, because there's a small amount of literature suggesting that it is possible in hemodialysis patients. But I think this has really focused my mind on it, and obviously for you as well, Eleanor, you focus a bit more on what can we get out of it, and if you see the urine output dropping, then it's quite tempting to add in 250 or 500 milligrams of furosemide and see if you can buy them a bit more time on twice weekly.
Fiona?
Hi there, I'm
Hi,
Fiona.
Fiona.
I'm a sort of dietitian sitting in sort of Dumfries and Galloway, so it's just a sort of like a couple of questions really, Stewart. I just wondered if there was sort of like criteria for sort of like starting patients on dialysis, and whether that was sort of like done earlier to sort of like preserve that sort of like residual renal function, or what criteria you had with regards to that.
We didn't change our criteria, and we're reasonably confident that we haven't actually changed in practice, either who we put on dialysis or when we start. So yeah, we start when they become symptomatic, and we will do a bit of work to look and just check that the starting GFR, EGFR hasn't changed between the incremental era and the non-incremental era, but we didn't plan to, and we don't think that we have changed our criteria for starting. And similarly, would you have a lower threshold for starting people on haemodialysis for that, the sort of grey area with where you could persuade them to go down a conservative care route, or would you start them on haemodialysis? We don't think our threshold has changed, but there's a possibility that you might be a little bit more likely to have somebody in their 80s end up on haemodialysis if you think, you're only going to be on twice weekly dialysis. It's not as severe, not as much of a burden as 3 times a week dialysis. So we don't think that we've done that, but it's possible. But I would say certainly with the second category, I'm not sure that's a bad thing.
No, that's great. And I had just one other question, sort of like relating to sort of like the electrolyte change, sort of like with the 2-day gap, or sort of increased sort of like dialysis gap. Was there sort of like a more robust education of patients, like with regards to sort of like hyperkalemia, from your sort of like, dietitians, sort of like specialist nurses? Just a query.
Yeah, no. It seemed that their residual kidney function and dialysis was enough to clear their potassium. So I think this is a group of patients where you can more clearly say these people need less dietitian input, and you can focus the dietitian input on the people who have lost their residual kidney function, where we do have the patients who are running into potassium and phosphate problems, but not largely in this group.
That's great. Thanks very much.
Thank you, Fiona. Now, Sasha, Adalat Sasha.
Hello, hi.
Hello, hi.
I'm a paediatric nephrologist from London.
Yes.
I had a couple of questions. One was about, what you're measuring. So residual kidney function in terms of, electrolyte and fluid balance effects, and twice weekly versus 3 times a week. But I guess I'm slightly worried about the things that you're not measuring. So things like cognitive decline. I know that you talked about your patients having very positive benefits from their quality of life in terms of not having to come up for another day of dialysis. But in terms of impact on these things that you're not measuring, such as the effects on their brain and cognitive decline, did you notice any differences, or was that something that might want to look at?
No, we didn't look at that. No, I mean the cognitive decline, I would say we don't notice it as an issue in our twice weekly cohort. We do notice it in the 3 times weekly cohort after they've lost their residual kidney function. And I suppose you could argue, is there some uremic damage going on that we're not measuring that builds up and increases in the longer term? It can't exclude it, but it's certainly not evident clinically at all. This is a patient group that look well, and generally I think the thresholds we've chosen for changing to 3 times a week are relatively conservative, and the ones who have gone on beyond our usual threshold have also stayed well, so without evidence of cognitive decline or any other kind of decline. So I don't think so, but I can't give you.
Could I possibly come in? Sorry, not to interrupt, but just could I take a counter argument that there's quite good evidence that a lot of the cognitive decline is due to recurrent crashes on dialysis and ischemic events, cerebral events. So actually, by optimizing their urine output, reducing the amount of UF and reducing the crashes on dialysis, there's a reasonable argument that it's neuroprotective, same way as it's myocardial protective and preserving those remaining nephrons.
Fantastic.
Better answer than mine, Eleanor. Thank you very much.
Yeah, I think there's arguments both ways. I think that is that potentially, does have an impact. But we also know that, even in early CKD, you can have cognitive impacts that progress. So it will be interesting to look at. The other question that I had was about, so, you're talking about financial benefits, sustainability benefits in terms of, fewer dialysis sessions. But have you thought about home dialysis for your patients, and how many of your patients do home hemodialysis?
We're a small number. So we've got, I think now 5 patients on home hemodialysis. So yes, we would prefer them, and this is not in any way stopping them from going home. But yes, we would have the same approach, and you can go on your home hemodialysis, and we have a very different dialysis schedule for them. But as of now, if you came to us and went on to home hemodialysis, you would start incrementally, and you might go and do your home hemodialysis twice a week, but then progress on. And our home hemo patients are typically dialysing 5 or 6 times a week. So yeah, we've sort of broadened the palette of what we offer our patients, from the standard, from just everybody's dialysing 3 times a week to a number of patients can dialyse twice a week, and some of them need to dialyse 4, 5, 6 times a week. And of course, some of the hospital in-centre ones are dialysing 4 times a week, and it just buys you a bit more capacity to be able to offer that. So yeah, twice a week for those who need it, but it frees up capacity so other people can get more dialysis.
Great, thank you.
Thank you. And now, Gloria.
Thank you, Marta, and thank you so much for the presentation, Stewart. So I have a question and a comment. My question is, do you use the same criteria for deciding whether a patient can start on 2 sessions a week for peritoneal patients to decide how much patients need on peritoneal dialysis?
Sorry, say that again. Do we have the same criteria for starting incremental?
Yeah, could you use that criteria to decide how much dialysis patients need on peritoneal dialysis?
Yeah, so we are trying to implement incremental peritoneal dialysis as well. There have been some personnel changes in our PD department, and there is some resistance to that idea at the moment, but we're working on it because it makes absolute sense. And interestingly, when we started doing this, I think most units have actually come at incremental dialysis the other way around and started doing peritoneal dialysis incrementally, and then saying, well, why don't we try that in hemodialysis? And we're doing it the other way around. But yeah, I think incremental peritoneal dialysis makes perfect sense and is absolutely the way that it should be implemented.
Okay, so thank you so much. The comment I wanted to make was that I used to work with a service in North Central London, and we used incremental hemodialysis. So it worked very well. However, the criteria we used there was very different. Yeah. So the 2 hospitals I am working with at the moment, I tried to introduce this criteria to them, so for consideration, but the criteria wasn't too easy to follow. So coming across to the criteria you described today, I think it will be much easier for them. And the criteria we use at the Royal Free Hospital was B2M. So it was B2M, BMP, residual kidney function, and by impedance. And that way we decided how much dialysis patients would need. So now I have another question. So do you think you could talk to my colleagues about a similar presentation, maybe shorter presentation with the criteria moving forward, please, because they are really looking forward to know about this type of criteria rather than the one I introduced from North Central London. Is that something you could do for us?
Yeah, very happy. Yeah, always happy to talk about incremental hemodialysis. I'm an enthusiast, and happy to have an opportunity to spread the word. I might pick your brains about the use of BNP and beta-2 microglobulin, because we don't measure that routinely, and that's the second time I've heard that London are doing that, and I'm curious, and I need an argument to convince our biochemists that it's worth spending the money on.
Okay.
I told them that, and they sort of shrieked.
Fantastic. So I will arrange a meeting, and we can take it from there. Thank you.
Great. No, thank you.
But maybe just for trying to finish, I have two very quick questions in order to what Gloria was saying, and I was asking you before. Is there any? I can see there's not a national protocol for incremental hemodialysis, so for everybody trying to do the same thing. Will be a possibility to try to develop this?
Yes, I'd be keen to see that, and I think we've probably got an opportunity in Scotland which should be more achievable, because we were having that conversation before we started. It's a much smaller community, but it'd be good to get it across the UK and into UK Kidney Association guidelines to say that they support this. And but yes, I would imagine for that it might come under greater scrutiny of the published evidence, and there's still limited published evidence, but I think that it's going to be yet another hemodialysis topic where you never get the big randomized control trial to prove that it happens, to prove it's the benefits or otherwise. So yeah, they should concentrate on what's practical, I think.
From Spain will come in very short time some more evidence about this.
Good.
So, and talking about residual renal function, preserving it, and very, very, very beautiful results. So,
good.
Yeah,
that'll be really interesting to see. Yeah.
And my last question, because in Spain we usually try to begin with one session. You have talked about beginning with 2 sessions. So have you thought about that? Beginning first with one, then go to twice, and then.
I have a work in progress. I told you about selling this to my colleagues as twice weekly. I sold it to them. I tried last month. One of my colleagues' head exploded. It did not go down well, but that was probably for there was some politics there. So yes is the answer. One of the difficulties I had was there's little published evidence on once weekly hemodialysis. There's even less on once weekly, but yeah, so you're using it in Spain in
Spain, in Cáceres, in my colleague Javier Deira. He has great experience. And Eleanor is saying that some Australian colleagues too. Eleanor.
Yeah, I think I came across the name Javier in
Javier Deira.
Somebody who's doing it.
Yeah. So I think if there are no more questions, this was an amazing presentation, Stewart. Well, I don't know if Steph, very quickly, Steph.
Sorry, Martha, sorry. Just a quick question for the once weekly dialysis, your colleague, what was the starting eGFR of the patients in that unit?
Sorry, Steph.
At what renal function did they start on dialysis?
The things I was looking at, they'd had the same threshold for starting dialysis, but it was the point at which it was unclear at what urea clearance they were converting to twice weekly, because you'd want to go once weekly, then twice weekly, then 3 times weekly. I think you'd start them at the same
-4,
so when
I think. Yeah, it was -4. So it's a bit higher.
Yeah.
Okay. So thank you again. Thank you very, very much. I will put this recording in our network, so for everybody if they want to review. But I think, Stewart, you have given us all the resources and all the motivation for just trying to begin with incremental dialysis if we don't have that program yet, and in order to be more sustainable. So thank you again very, very much.
My pleasure.
And thank you to everybody who has been connected all this time, and for all this amazing discussion. Okay.
Thank you for the invitation. Thank you for the audience.
Thank you.
Thank
and
you.
the questions.
Thank you.
Thanks.
Bye.
Bye-bye.
Bye.
Thank you.